Bismillah, ladies and gentlemen, good evening. And once again, we are here with the weekly webinar on endoscopic ultrasound and ERCP from basics to the advanced. And I'm really thankful to Asian Endoscopic Ultrasound Group, Pakistan Scientific Gastroenterology, and all the other educational institutes for cooperating with us, for sponsoring us for this weekly educational activity. And this time we have a very important topic, endoscopic ultrasound anatomy of the liver. And for this, we have Vikram Bhatia just across the border from Delhi. He's a professor in Institute of Liver and Biliary Sciences in New Delhi. He's a well-known, renowned name in the endoscopic ultrasound, an accomplished person, and he has been having a passion in the endoscopic ultrasound, and in particularly in the new avenues, new frontiers of the endoscopic ultrasound. Um, People are there on Facebook, people are there on the Zoom platform. I'm sure they're going to enjoy this talk. The house will be offering the question and answer session by the end of the talk. Dr. Vikram is going to initially give a talk on endoscopic ultrasound anatomy of the liver, and then me and Prasad will entertain the questions. By the way, it's Dussehra as well. So happy Dussehra to Dr. Vikram and all the people in India. Vikram, all yours, please.
Thank you, Dr. Tyab. So thanks to my good friends and colleagues, Dr. Tyab, Dr. Saad, and everyone who is there. Please let me know if my voice breaks in between or if I linger on for too long. I'll be speaking on endoscopic ultrasound anatomy of the liver. And obviously, as Dr. Tyab told me, some people are doing EUS, others would be contemplating starting EUS, and others would at least be having some experience with transabdominal ultrasound. So we shall sort of see how the anatomy of the liver is from a different three-dimensional perspective, slightly different from the CT scan, although we shall touch some of the CT scans because the pathology detection starts with the CT scan. And then I'll tell you how the CT scan translates into the three-dimensional anatomy, which you see with a ultrasound from outside and with a EUS from the inside. So the first question is, why should you want to learn about the EUS anatomy of the liver? This is because once you do any EUS, the liver is right in front of you. And you are increasingly seeing unexpected small liver lesions on EUS, also on transabdominal ultrasound and CT scan. When we see lesions, we are doing increasingly the EUS FNA of liver lesions, and many times we find metastasis. So if you find metastasis, you can't get away by saying it is in the left lobe of the liver. The surgeons and other people would want to know the exact location of the lesion. So you have to be more expressive about what you find in the liver when you see something on USFNA. Can you see my screen now?
You're on the second slide. Yeah, that's right. Perfect.
Okay, so now can you see the third slide?
Yes, we can see the third slide.
Okay, so I hope you can see the left hepatic vein, which defines the left portal caesura, the middle hepatic vein.
Excuse me, we are on the second slide. Why?
It's again getting stuck?
It's getting stuck.
Now can you see?
Well, we can see the slide number 2. Why?
Okay,
yeah,
now
yeah, that's moving fine. That we on the next slide.
Yes. So now I am showing you the PowerPoint. I was working in Keynote. I think PowerPoint will work fine. So sorry. So I hope you can see the liver cut section now.
Yes, we can see the liver cut section.
Fair enough. So this is the left portal vein, which defines the left portal caesura, the middle hepatic vein, which defines the main portal caesura. And the middle hepatic vein actually corresponds to what is called the Cantilese line. Now, please remember your anatomy that the Cantilese line runs from the middle of the gallbladder bed to the middle of the IVC and is the demarcation between the right lobe and the left lobe. So this is the main portal caesura, which also corresponds to the gallbladder, because you are going to see the gallbladder on ultrasound and on EUS. And this corresponds to the middle hepatic vein, which you will see on EUS in the gallbladder bed, which also corresponds to the Cantilese line. So we are all talking of the same thing. The right portal vein is most variable, but this divides the right posterior and anterior sectors with segment 5 and 8 in front and segment 6 and 7 behind. Now, okay, so let me go forward and then we will see. So this is the CT demonstration of the segments. Let us recapitulate this. This is the topmost section. And in the CT scan, we are seeing clean axial sections. This is the left hepatic vein, segment 2 above and segment 3 in front and below. the middle hepatic vein with segment 4, the right hepatic vein dividing segment 8 and 7 on the top. Then as we go down, the left portal vein is superior to the right portal vein. So when we see the left portal vein, we start seeing more of segment 3 on the left side, but on the right, we still have the top segment, segment 8 and segment 7. When we, I don't know what is happening to this. Sorry. So when we go down, we have the right portal vein. And when the right portal vein is seen, which is at a lower level than the left portal vein, on the left, you have segment 3 left. And on the right, you have segment 5 and segment 6 seen. And further down, the right portal vein is also gone. And now you have the inferior segments, the segment 3, the quadrate lobe or the segment 4, lower part, segment 5 and segment 6. I hope this was clear. Was I audible, please?
Yes, we can all hear you clearly.
Okay, sorry, I'll have to ask. So how is EUS different from the CT scan that I just showed you? So there are two basic features. One, EUS is a real-time dynamic evaluation. Unlike a CT scan, where you have a strict cutoff or strict planes defined, in a EUS you have innumerable scan planes and you actually roll over the landmarks. Plus, please remember that strictly speaking, there is no strict anatomical demarcation, no line seen in the real time in the liver parenchyma. The liver parenchyma is continuous. And contiguous segments, which are segments lying one next to each other, may be seen in one plane. And when we segment the liver, these are rough approximations. So basically, there are two stations when you define liver anatomy by EUS. One is transgastric and one is transduodenal. Very simple till this point. And please remember that we refer to three EUS landmarks: the vascular landmarks, the ligaments, and the surface landmarks. The vascular landmarks are the portal vein branches, which are recognized by the thick hyperechoic walls. They have a lot of fibrous tissue in their walls. Then you have the hepatic vein branches, which have thin and imperceptible walls. And then you have the cava, which can be easily recognized. Then you have the ligaments, the ligamentum venosum and ligamentum teres, which are very important landmarks in EUS. These ligaments are seen as thick hyperechoic cords running from the surface of the liver to vascular structures inside the liver without any lumen. And then you have surface landmarks. You can see the gallbladder, which straddles segment 4 on the left and segment 5 on the right, and forms the beginning of the Cantilese line, as I have just mentioned. And also you can see the falciform ligament floating when there is some ascites. So this is just to show you the relationship of the portal vein and the hepatic vein radicals, which are very important when you are doing a transabdominal ultrasound or a EUS. Please remember that the portal vein and the hepatic veins are entwined like the fingers of the hand. What is to be remembered is that in general, the portal vein radicals, the larger portal vein radicals and the hepatic vein radicals are perpendicular to each other. So if this is a hepatic vein, which you can demonstrate in a long section, you will see the big portal vein radical in a round section. And if you demonstrate the portal vein radical in a long section, you will often see the hepatic vein in a cross section. This is a basic fundamental principle. Second thing to remember is that as I just told you, the main hepatic veins divide the sectors of the liver. They demarcate segments, while the segmental portal vein divide the superior and inferior aspect of the liver, but they then enter into the segments. So if I'm following a portal vein radical inside the liver, the segment which it defines is all around it. But if I'm defining the sector or segments by the hepatic vein, it is the demarcating line between the segments or the sectors. I hope these principles are clear. So I think most people would want to study linear EUS imaging of the liver. I have also some slides on the radial EUS imaging of the liver, and all of these I have published for the first time. Can I proceed, Dr. Tyab? Is there any question till now?
No, not yet. Please
proceed. We'll have questions towards the end of the talk, Dr. Bharat.
Fair enough, but you can always interrupt me in between. Okay. So when we do a linear EUS imaging, let us see the CT scan. This is a CT scan of the liver. This is the stomach. This is the G junction. So when we pass the EUS scope, we start imaging from this point where my cursor is. I hope you can see my cursor. But the CT scan, as you know, is oriented as if you are looking into the human body from below above. This orientation does not work in EUS. What we would like to imagine the EUS is like this. So let me take you back. This is a CT scan, but on EUS, we imagine structures like this. Now we are looking into the human body like the textbook of a Gray's Anatomy from above down. So this is the stomach. My linear scope is here when I begin, and the probe points anteriorly. So when this probe is in my hand, the knobs are neutral. The probe is then pointing anteriorly, and what I see is the left lobe of the liver. Now this is the reverse orientation. I'm looking into the human body from above below. And then the standard maneuver is to rotate the probe clockwise. So when I rotate the probe clockwise, starting from the left lobe, I will roll over the left hepatic vein, the umbilical part of the portal vein, see the caudate lobe, the cava, the push down to see the liver hilum, further rotation to direct the probe behind to the aorta, further rotation to the celiac axis, the kidney and the spleen. These are the basic maneuvers of a linear US study, and the interpretation of the liver is as we rotate it around the landmarks. This is a cartoon that I have drawn freehand myself, just to show how the imaging is. Unlike a transabdominal imaging, please remember that the probe beyond the G junction in the proximal towards the front down to the inferior and this is the falciform ligament on the liver surface. So we see the caudate lobe between the cava and the probe. EUS, we will see segment 2 and 3 in front, and then as we rotate, we will see the caudate lobe. Here you can see the rotation between the probe and the cava, and beyond the caudate is the segment 4, and you can see the right lobe is very far from the stomach, but you can see some part of segment 8 superiorly. Try to imagine this lobe. So what is the demarcating line between segment 2 and segment 3? When we talk of a hepatocgastro, the first thing you see when you pass the linear US scope beyond the G junction with the knobs neutral, and you are just holding the scope, the part of the liver that you see is the left lobe of the liver. And you can well see that you can see the segment 2 and segment 3 and the left hepatic vein. So this is the left hepatic vein. Segment 2 is closer to you. Segment 3 is further away from you. And to get segment 3, you will have to push the scope in and little bit part of the portal vein. This is the umbilical part of the portal vein. This is a drawing that I have made on the iPad. This is the umbilical part of the portal vein, goes to join the horizontal part of the portal vein, which lies on the undersurface of the left lobe of the liver. And on EUS, this left portal vein goes down into the porta hepatis. I think most people would have seen this imaging. Just recognize these structures. And as we had mentioned, just below the probe, because we are imaging from here, is the caudate lobe. with the cava below, and the segment 4 is seen beyond the caudate lobe. We see the middle hepatic posterior segments of the right lobe deeper down. So this is just to explain to you the principle. This is just to show section. You would reconcile separating segment 2 from segment 1 or the caudate lobe. But on EUS, we are imaging from oblique. So we see segment 1 and segment 4 in the same direction. We cannot demonstrate segment 2 and segment 1 together, unlike a transabdominal ultrasound. These structures on US are very important to identify. A white band-like structures goes to the right of the image. This is the ligamentum venosum, and this will go to the junction of the left portal vein and the IVC. So these relationships are fixed. Ligamentum venosum extending from the left portal vein to the junction of the left hepatic vein and middle hepatic vein entering into the cava. A thick structure goes to the left of the screen. This is the ligamentum teres. And if you remember the embryology, the ligamentum teres carries blood in the fetus via the left umbilical vein to the left portal vein, then through the ductus venosus into the heart, and through a patent foramen ovale bypasses the lung to enter into the left side of the cardiac chamber. So this is the obliterated fetal circulation in the adult. So ligamentum venosum, left portal vein, ligamentum teres, and between these are liver part which you see is the segment 4. This is the middle hepatic vein, the termination of the middle hepatic vein. And what is deeper is the segment 8. So this is how you identify the segments on a linear EUS. All this has been defined by us for the first time and published. Now, we can also see with a linear EUS probe the liver hilum. And how do we see the liver hilum? This is because the stomach is arched over the spine. So when we have the probe, we are looking at the orientation is reversed. And we see the portal vein in front, the right hepatic artery between the portal vein and the bile duct. The cystic duct and the gallbladder can also be seen. And the part of the liver which is lying over the hilum, as you know, is the quadrate lobe or the lower part of segment 4. And you see the portal vein trunk. What goes down is the right portal vein, and what comes up is the left portal vein, which we have been tracing from the G junction. We can also see the gallbladder from the proximal stomach. Now, how is that possible? Because once you are beyond the G junction in the proximal stomach and you lift the probe up, you are looking into the patient from below up. You are looking into the liver from below up, and like this. And you can see the gallbladder like this. And the segment of the liver that you see here is segment 5. So segment 5, which is part of the right lobe, can be seen from the proximal stomach, can be impossible to or very difficult to see from the duodenum. So please see segment 5, I think, also from the proximal stomach. So I have shown you how to see segment 2, segment 3, segment 4, or the caudate lobe, segment 5, the ligaments of the liver, and the hilar structures. And this is just to show you a video. You will see the left hepatic vein segment. So it is as if I am repairing a car and I am looking from below upwards, and then you will understand the orientation in the duodenal bulb. So this is the hilar portion of the left portal vein, umbilical part of the left portal vein, and this is the right portal vein. So when you demonstrate the liver from the duodenum by rotating your hand to the left or anti-clockwise, you will see the This is the kind of demonstration of the radicals that you will get. This is even in the CT scan, the hilar structure shows you these are anterior. Then are the hepatic artery. Then are the portal vein. So regardless of the variations in the hepatic vascular structures, this orientation at the hilum sort of remains true. First, the hepatic ducts. Number two, the hepatic artery. Number three, and left are stacked at the you use the duct. I am in the duodenal bulb. My hand is rotated to the left. The wrist is dropped. So I have rotated to the left. My big wheel is down or the probe is pushing up. And this is a cross section of the hila. This is a very important demonstration for Mirizi syndrome, gallbladder, neck pathologies, hilar cholangiocarcinomas. So all EUS people should know how to image the hilum from the duodenal bulb. You enter the duodenal bulb, inflate the balloon, put the big wheel a bit down, and just let your wrist drop on the left side so that the probe looks up. And this is what you will see like the CT scan. The ducts are anterior. Then you have the hepatic artery. So this side is right. This side is left on the screen. So you have the right hepatic artery going up. You have the right portal vein going up. You have the right hepatic duct. This is the biliary confluence, and this is the left hepatic duct. And by slightly moving the scope, you can see all of these structures, and you can tell the surgeon how far the cholangiocarcinoma is extending into which segment of the liver, and what is the bismuth category of this hilar block. The the liver segment, which is behind the hilum, as we have studied, is segment 1. What is on the left side is segment 4, and what is on the right side is segment 5. So segment 5 is in front of the right hepatic artery. Segment 4 is in front of the left hepatic artery. Unlike what is written in the textbooks, you can see a very large part of the left liver also from the duodenal bulb. So this is again imaging from the duodenal bulb. The proximal left hepatic duct is better traced from the duodenal bulb. This is the left hepatic duct. You see segment 4 here, and this is the umbilical or the ligamentum teres, which you can see from the duodenal bulb. The left hepatic artery normally takes a loop and like this, and this is very characteristic. And if you now turn the small wheel to the right or up, you can demonstrate. So if you take the right portal vein and you turn the small wheel up, you can see the right portal vein in the right bile duct, and this is the segments bile ducts and the portal vein till the secondary divisions with a linear EUS probe. This is just to show you a case of hilar cholangiocarcinoma. This is again a cross section at the hilum from the duodenal bulb. This is the hilar plate. This is the left hepatic duct. These are dilated ducts. The hepatic artery, the portal confluence. By putting the Doppler H flow, we can see the vascular structures. You see that there is some thickening here, and this is the hilum. And you can see the very thin thickening of a clad segment in the right hepatic artery and right portal vein, which go on this side. I think this video is not running fully. Okay, so Dr. Saad, do you want me to briefly tell about the radial EUS imaging? This is, I don't know if you do radial EUS. This is also very complementary.
Yeah, I mean, if you have time, why not? Although most of us are like I'm sure you do in your practice using linear, but it's not, unless
I think it will be easier for you to understand the anatomy in both the perspectives. This is again been first time described by myself, and it is also extremely interesting. I'll just show you in 5 minutes.
Go ahead. Yeah,
Please,
go ahead.
yeah, it's good that you
So
go ahead. Yeah.
unlike a linear, and I have published this also, and this is a very underappreciated modality. A radial EUS scope is a very simple scope, cross-sectional anatomy, easy to to understand, but very underappreciated. So in radial EUS, there are three stations. One is from the G junction and proximal gastric body, where you see the superior segment, segment 2, segment 4A, plus please note that segment 8. Segment 8 can be very well seen with a radial EUS scope, not so with the linear EUS scope. You can see the caudate very well. You can see the left hepatic vein and the middle hepatic vein with confidence. Unlike what is written in the books, you can image the liver, hilum, and S4 very well from the mid gastric body, like the linear EUS scope from the proximal gastric body. From the duodenal bulb, it can show you portal vein bifurcation, the transverse part of the left portal vein, the left lobe, but also these segments which are exceptionally difficult to see with the linear probe, which are segment 5 and segment 6. Segment 6 you cannot see with the linear probe. So radial EUS does have some advantages. Now, this is a standard image which all of you would recognize. We have all been taught that you keep the aorta at 5 o'clock. This is the crus of the diaphragm, which is the sonological demarcation between the thorax and the abdomen. This is the fundus. The fundus is on the right upper quadrant of the EUS image. Standard EUS image. Till now, everything is very clear. This is the spine. But now let us start looking at the liver. This is the fissure for ligamentum venosum. And this is the caudate lobe, which is again very close to the probe, and between the probe and the cava, like the linear EUS scope. So the imaging is the same, only the orientation is perpendicular. So the caudate lobe between the probe and the cava, ligamentum venosum, which separates the caudate lobe from segment 2 and segment 4. And you can see the left hepatic vein, the middle hepatic vein, and segment 8 very clearly. So we see this all the time. Just recognize what we are seeing. Now, if I put the big wheel down and push right on the top of the liver, this is the right ventricle, not the left ventricle. The right ventricle is closer to the EUS probe. So the main cardiac chamber that you are seeing is right ventricle. Left ventricle, you can see pulsating on that side. And you see the left hepatic vein, and a large part of the top of segment 4 is seen from the G junction. If I pull back over the cava empties into the right atrium and goes forward into the right ventricle. And this is the coronary sinus of the right ventricle, right atrium, aorta, and the left lung. Now we push back again like this. You can all recognize the celiac trunk, the club head sign. But what is not commonly recognized is that you can actually trace the celiac to the splenic artery and also the hepatic artery. And you can take the portal vein from the club head to the liver hilum like this. And so you see the portal vein, the IVC, and the hepatic artery and the liver hilar structures very well with a radial EUS probe from the mid-gastric body. And if you lower your hand further, you can see the entire length of the left portal vein, segment 2 and 3 from the stomach. So this is the left portal vein, and this is the right portal vein going down. So this is the radial EUS imaging, big wheel down, probe pushed up, and the wrist dropped from the mid-gastric body. And this is the kind of orientation you can get with a radial EUS probe. So you can see all the hilar structures, not only with the linear, but with the radial EUS probe. So you can see the lesser curve of the stomach, the left lobe of the liver. This is the area of the left hepatic artery, the portal vein, the cava, and the segment 2, segment 3, and the caudate from the stomach. Now again, we are all very familiar with this image. When we enter the duodenal bulb, we see the portal vein. We also know the pulsating IVC on the opposite side of the duodenal bulb, either in long section or in cross section. And we should be able to recognize the right atrium entry of the IVC from the duodenal bulb. We have all seen these images, only I'm telling you the interpretation of what we are seeing. And this is a cartoon that I have drawn of why you see the IVC and the portal vein on opposite side of the duodenal bulb when both are behind the duodenal bulb. You see the converging duodenal folds here. This is the portal vein, this is the IVC, this is the, sorry, this is the left portal vein, and the gallbladder. Note that the left portal vein and gallbladder are approximately perpendicular when you are doing a radial EUS imaging. And let me show you how. So this is the standard imaging from the duodenal bulb. All of you would recognize the portal vein. This is the right portal vein, and this is the left portal vein from the duodenal bulb. And what you see here is the kidney, and the segment that is adjacent to this part is segment 6. So this is how you see segment 6 with a radial EUS probe from the duodenal bulb. And this is the right portal vein, this is the left portal vein, and you see the bile duct here and the portal vein and the confluence here. This is the standard standard imaging with a radial EUS probe. Also note that you see the IVC on the opposite side of the duodenal folds. You can also see the right adrenal at times. You can see the anterior abdominal wall at times from here. So this is the bile duct, the stack sign, the portal vein, the head of the pancreas, and what I am labeling is the left portal vein. This is the right portal vein, this is the portal vein, this is the bile duct. This is the left portal vein. And now if you drop your wrist, you can trace this left portal vein all the way down from the duodenal bulb, all the way down. This is the transverse part of the portal vein on the undersurface of the liver till you reach the ligamentum teres. This is all transduodenal radial EUS view. And this is the gallbladder. Since the gallbladder and left portal vein are perpendicular, if you want to demonstrate the gallbladder from the duodenal bulb, you make the portal vein vanish, and then you will see the gallbladder. You can see the anterior abdominal wall, ligamentum teres, and portal vein. And since you see the portal vein, this is the section in which it rounds off to the umbilical part. And now you see the gallbladder, and you can demonstrate it with the fundus right and with the fundus left orientation. So my last 2 slides, all this is very good, but what are the limitations of EUS segmentation? I have tried to tell you the basic principles of imaging, but if the patient has fatty liver, if he has calcification, if he has aerobilia after the ERCP, the imaging becomes less crisp. After surgical resection, the interpretation of the anatomy becomes more difficult. In cirrhosis, the imaging becomes very difficult. So these basic principles have always to be kept in mind about the relationships of the different structures inside the liver. And if you want to really study the liver in a particular patient, it prolongs sedation time, but a gross overview doesn't increase should be part of any EUS study. Now, all of this I have told you, but we need further studies of the reliability of what I have told you, reproducibility, which means how many endosonographers can reproduce all of these, and how good is our accuracy in picking up these lesions. So my proposal is that you see CT visible lesions, and then you try to make corresponding EUS imaging in the beginning to train your eyes and hands. A different operator should be able to demonstrate the same thing in a standardized way with different equipment. And what would be very interesting is how many more or less lesions are detected by the use of EUS vis-a-vis CT or MRI. So with this, I end. I hope I have been clear about this slightly difficult topic.
Thank you,
Dr.
Vikram.
Tyag?
Vikram, not only that you have been clear, you have been crystal clear, and your concepts are amazing. Translating CT scan into endoscopic ultrasound and endoscopic ultrasound correlation with the transabdominal ultrasound, that's been wonderful. As regards to reliability and more number of people confirming your observations, I think it's something which is a matter of discussion. We have Dr. Khalid Hassan with us. With that, we have other people in the audience, and all I can say is that your presentation was excellent. I have been posted a few questions.
Thank you.
First of all, question is that how do you say, what is the difference between endoscopic ultrasound and transabdominal ultrasound? What is the major difference between the two? Are they
So
complementary to each other, or they are Yes.
No, they are very complementary to each other. So the only thing is that we will usually not do. Am I audible, please?
Yes, you're
Yeah, yeah.
audible. You're audible.
So we will often usually not do a EUS study just to interrogate a liver lesion, which we can see with transabdominal ultrasound. Transabdominal is also a real-time method. This is also ultrasound. The main difference between the two is the orientation. Here you can create artificial planes, vertically, subcostal planes, and axial planes with the transabdominal ultrasound. With the EUS, you must understand that the patient is moving, the organs are moving, and most of the imaging planes are tangential. So while the transabdominal ultrasound imaging have been standardized, you make axial planes, subcostal plane, transcostal planes, and those have been standardized by the radiologist. These are very new concepts. And the planes with which we image the liver are most often tangential, moving in a actively breathing patient who cannot cooperate by holding his breath. So yes, they are complementary. And our job is to understand, because we can see things in much more magnified way compared to the transabdominal ultrasound. So our pickup is way superior, particularly for vascular structures, for bile ducts, for individual biliary radicals. We can trace things till the segmental bile ducts. We can look at portal vein branches, hepatic vein branches. So like EUS anywhere, our magnification is superb compared to transabdominal ultrasound.
Vikram, there's a question from the audience that you said that in cirrhosis, it is always difficult to interpret the images. So, what is your experience in doing the liver biopsy, especially in terms of people who are suffering from NASH cirrhosis or the people who are suffering from post hepatitis C or B related cirrhosis? Are you doing it? And what's your experience?
So, Dr. Tayab, see the cost of doing and the effort of doing a EUS guided liver biopsy is much more than a percutaneous liver biopsy. Let us be honest. We,
Yes.
as endosonographers, we always want to do trans EUS procedures, but from the patient's perspective, it is much cheaper and convenient for him to get a trans-abdominal ultrasound guided biopsy than a EUS guided liver biopsy. Having said that, if I'm doing a EUS and I'm inside, I have opened a needle. I can use the same needle to sample the liver, the left lobe mainly, and then I can get adequate liver biopsy specimens, which usually 4 to 8 portal tracts for adequate histological examination. This is most often required in the setting of chronic hepatitis. When the cirrhosis is advanced, the therapeutic advantage from any liver biopsy by whatever route is then limited.
Perfect. Have you ever tried doing a radio frequency ablation of liver lesions as well through the stomach?
No, I have no experience, but having said that, in my experience, picking up HCC with a US probe somehow has been very difficult for me. When I
Hmm.
have thought it is a HCC in a cirrhosis, I have been more often wrong than right. And when the radiologist tells me there is a HCC and I am looking at the same segment, I am often able to perceive the HCC which the radiologist is described. So with the cirrhotic liver, I think we need to train our eyes more, or maybe the equipment needs to be trained better, the improves more before we can start treating HCC. Because the regenerative nodules and the liver nodularity and the echo texture in a cirrhotic liver
Yeah,
can be
they
exceptionally
look very
confusing in my experience.
I agree. Khalid, Dr. Khalid is from Florida Hospital. Khalid,
Uh, so,
what are you?
Vikram, I'm Mohammed. I'm with Shaim and Rob Haas
Hi,
in
hello,
Orlando.
hello.
And hello, very nice talk. Thank you so much.
Thank you.
It was a few things I'll just add. Obviously, you have described everything very precisely and concisely. EUS and I totally agree with that part. Like you have to take a look at the practicality of both imaging as well as tissue diagnosis. With regard to parenchymal liver disease, I totally agree. I think if you're in that part of the word, then maybe percutaneous works better. If, however, you are already in the patient and patient was being evaluated for any liver disease, I mean, biliary obstruction, but you don't find it, and everything is pointing towards the liver parenchymal disease, and you already have a consent, then yes, you can get the liver biopsy with the EUS, keeping in mind majority of the time, other thing I wanted to mention was like majority of the time what we really see on EUS is left lobe of the liver. Approaching the right lobe of the liver for biopsy is not easy. And you have to traverse a lot of liver to get through that and the vessels as well. You can probably get to segment 5 easier than the other segments for the purpose of biopsy. And also then depends on the needle. That's another discussion as well, because it sometimes it's really a patchy disease process. So we need to get a biopsy from both segments. So you can do that, but for practical purpose, probably the percutaneous is a better way to go. However, with regard to metastasis of any sort, it is much easier to get a liver biopsy while a liver lesion biopsy with the EUS, and it is very, very cell-rich specimen. You really don't need much tissue. You just need only 1 or 2 passes, and it would be a lot of cellularity of that specimen. And also another point with regard to overall imaging, keep in mind that the penetration of ultrasound waves, when it goes beyond 6 centimeter, it becomes very fuzzy, a lot of noise. You really don't see anything. And there's no liver which is only 6 centimeter thick. And it's a very big organ. So you always lose a lot of tissue texture when you are going through it with the EUS imaging. One other thing you described about very nicely about the portal vein and hepatic veins kind of running not parallel, perpendicular to each other when you look at those. And other very easy difference, what I have noted, if you just have no idea what you're looking at 2 vessels, which is hepatic vein or which is portal vein is, by looking at the periphery of that. You put in portal vein, the wall always is hyperechogenic. You will notice that. In hepatic vein, you won't see the wall. It will be very like, it will be just like a cyst without a wall. That's what you would differentiate. With regard to cholangiocarcinoma, you described very nicely about its extension into the hepatic left branches. Sometimes difficult to describe in right. Usually I say it's like if it's something above the hilum, ERCP spyglass, below the hilum, yes, you can do EUS. But one thing what you look at with the EUS, you're looking at that wall thickening. It's gonna be irregular. It would be thick. Normally, you should not see the wall of the bile duct or biliary system. But when you see that there is something wrong, either it's a cholangitis or it's a cancer or whatever. So when you're looking at that, so you thickness of the bile duct, what you are trying to do is you're looking at the wall where the thickness ends. That's the upper extension of that cholangiocarcinoma. So that's just few points to either add or stress, but overall, excellent talk. Thank you so much.
Thank you. I fully agree with the metastasis yield. And yes, we have been very efficient in picking up small metastases, 4 or 5 millimeters. They are very cell rich. They can be usually nicely targeted through a rim of liver parenchyma. And we always work with on-site pathology. And in our experience, usually 1 or 2 passes are highly cellular. And the additional thing which we often see in this part of the world is tuberculosis, particularly in patients who have disseminated TB. We are often surprised by finding small hypoechoic areas, the granulomas, oblique, the abscesses in the liver parenchyma, when none are seen by the CT scan and MRI and ultrasound done previous to the study. So in patients of tuberculosis, we have learned to look very carefully at the liver parenchyma, the left adrenal, and also the spleen for missed granulomas, because these seem to yield also additional information and very often are misdiagnosed or missed in cross-sectional imaging.
Vikram?
What is
Hi.
exactly granuloma in these?
Sorry, Rayas?
Yes, but I was just pointing out, putting a question to Vikram. What exactly do you see?
I wanted to, yeah, you do it and then I'll do it.
Okay, fine. What exactly do you see to pick granulomas of the left adrenal or liver or other tissues, what is the peculiar picture that you see?
So in tubercular granulomas, what we see are very hypoechoic, almost black lesions. These are variable sized dots, if I might, in the liver. They can have these are actually abscesses. So when we aspirate them, we get caseous material, and these can be very variable, but often, usually they retain a round space because they are liquefying and expanding the adjacent parenchyma. When you do a contrast ultrasound, in fact, the image is very interesting, particularly in the spleen, same in the liver. They are seen as filling defects, moth-eaten appearance in a otherwise illuminated liver parenchyma or spleen. So you see them as totally avascular areas in contrast ultrasound, which I'm very fond of in these areas. So unlike metastasis, obviously they have no vascularity inside, none.
Scott?
So,
Yeah,
so
my
sometimes we
thing
see,
was why
sometimes we see actually very fine speckling, and then you have to train your eyes. Sometimes you don't even see them as discrete lesion, but the liver looks very dotted or speckled. And then if you just take a blind FNA passes through the liver parenchyma and spread them with your on-site pathologist, the liver will show you granuloma. So not only abscesses, granulomatous hepatitis, once you start seeing, at least in some patients, will show you this fine speckled sort of peculiar echo texture, different from anything else. So you just blindly move your needle in the left lobe, spread out on the slides, and you see granuloma. So that's granulomatous hepatitis at times. And we have
Vikram?
had AFB positive without discrete lesions in a couple of cases, in such cases.
Okay. Okay, Vikram, while we are on this subject, what about complications related to liver biopsies, EUS guided liver biopsies? You see any?
Yes, so yes. So complications do happen. Unlike what people tell you, I have had major bleeds, although those were incidentally picked up, and luckily patients were admitted. The left hepatic artery courses right underneath. So the juicy part of the liver to biopsy is the left lobe, but left portal you can easily see, but the lesser by the probe pressure to make them invisible. And then you may obliterate the venous collaterals when you are pushing down on the liver. So be aware of collaterals running along the lesser curve of the liver. Number two, what is very dangerous and which I have caused a trouble is the left hepatic artery, which is very superficial, almost on the surface, and I've gone through and caused a big subcapsular hematoma in one of my patients. In retrospect, that was a mistake. So be aware of the left hepatic artery, be aware of collaterals, and respect the coagulation of the patient. And then after that, you are okay.
When you do a liver any biopsy for any sort, and if you put that you usually are, don't try to keep pushing it, and so just change your trajectory in that case, and if still doesn't go, come back, get out, take another path. Vikram, one quick question from practical point of view. What I mean is like liver lesions, if you see, and you have an option to have both radiological approach as well as EUS approach, because patients in these developed countries, sometimes they just want to go to sleep before you do anything to them. And they might prefer a EUS guided biopsy if possible. So from practical point of view, which segment lesions of the liver, if you have to like choice of both, and you have to pick EUS for that purpose, liver lesions of which segments are going to be easily approachable with EUS with less risk of complications?
So if I talk of the anatomical location, caudate is better for the EUS than for the percutaneous any day. In fact, caudate is often inaccessible by the interventional radiologist, while it is relatively easy for us. It is right beneath us. So caudate abscess, caudate metastasis, caudate lesions, EUS codes. Then we come to the left lobe, segment 2, 3, easy enough. Segment 4 is very variable. Sometimes you have segment 4 lesions coming right underneath you. Sometimes segment 4 will go behind the middle hepatic vein. You see it, but you can't target it. So segment 4 lesions can be tricky. They may be very easily accessible to the radiologist. You may see it, but it may be straddled by vessels, both from the duodenum as well as from the stomach. From the duodenum, you can often access segment 4 lesions, which have a vessel going through, going between the probe from the stomach, but that's a very looped scope position. So for me, segment 2, segment 3, segment 1. These I am very comfortable with. Segment 4 is, well, yes and no. Segment 6 is out. Segment 8 is practically out. Segment 6 is God knows where. And segment 5, you usually have the gallbladder sitting on top of it. So, but then from the duodenum, segment 5 lesion, which is big, will often come very close to you from the duodenal bulb. So segment 5, a large lesion I will take.
Yeah, so I absolutely agree with that. So this is what happens all the time, liver lesions, and we do get consulted for that. Can we get that with the EUS? So I just take a look at the CT or get a CT report and tell them what approach would be best. And segment 1, 2, 3, yes, you can get it. Segment 4, majority of the time, but unless it's really far away from you. Segment 5 from duodenal bulb, yes, you can get it. And when I did had this study on 22 gauge liver biopsy for parenchymal disease, so I was accessing both lobes. So that's the segment only I could access with the for that purpose. So segment 6, 7, 8, if there is a lesion on that, please tell them percutaneous, then instead of wasting time on EUS.
Sorry, one point I forgot. Also from the antrum. So sometimes you get a unique view from the antrum that's very unpredictable. So the kind of liver you see from the antrum is very unpredictable. But if you cannot access a lesion, it is always worthwhile to go and wedge in the antrum and rotate left and rotate right. And sometimes you find the segment 5 and strangely the left lobe appear in strange configurations there, and things are accessible.
Yeah.
So it's worthwhile to even look from the antrum.
So take home message is, don't waste too much time on trying to figure out how the whole liver looks on EUS, because your practicality is only really limited to majority of the time on left lobe of the liver. Pay attention to that. At this stage, some of us may not even remember all the anatomy details. So that becomes much easier and practical. So that's my approach usually to EUS. What is practical to you?
Vikram, we are into the last 2 minutes of the session. First question is practical question which has been put by one of the attendants. How to approach segment 3 duct front on from the stomach? What technique do you use to bring it right in front so that you may be able to puncture it through the lesser curve? And the apprehension that you have raised, that left hepatic artery may come in between. What exactly do you do to avoid puncturing the left hepatic artery?
No, so when you are going to segment 3, the left hepatic artery has already gone in. So there you should not be encountering the left hepatic artery. You should be encountering what we call A3, the artery to the segment 3. To answer the first part, to get segment 3, you usually push in and big wheel down, which means the probe up. So you sort of press against the liver deeper down and put the probe a bit up, which is what you want, a closer position for any puncture. So it is sliding down over segment 2, going further down, and sometimes it is rolling up and down. So this is where the anatomy comes in. You see segment 3 ducts here, you see segment 2 ducts here, and you roll over and you see them merging, and then you see them separating and merging and separating. So it is not difficult at all to recognize segment 3 ducts, because you can trace them to their joining, and you can then separate them out as you roll with the linear probe. But the best part to approach segment 3 obviously is to go further down a centimeter or 2 beyond segment 2, and put the big knob down so that you lift the probe up, and there you will get the segment 3 ducts, which will go down if you want to puncture them towards the hila.
Okay, so there's another question. Would radial imaging be better than linear below the G junction with large hiatus hernia or elevated BMI?
Yes, I use, people have condemned radial EUS probe, but I still use a lot of radial EUS probe. And honestly, in my country, I don't have the luxury of many EUS scopes. So I like to give my linear probe a rest whenever I want. I call it a rest. So I want to, I want to preserve my linear scope. So my radial EUS probe for diagnostic purpose, still I use it, particularly in the rectum. Obviously, it is the linear EUS probe. I do a lot of rectal work. And also in the upper, if I can, if it's a diagnostic procedure, I still utilize my radial EUS probe. And there's no shame in that. So that's cool.
Perfect.
I use mini probe, I use IDUS, I use transabdominal. I love ultrasound in any way. And that's, I think, how endosonographer should be.
Saad, do you want to say something?
It was excellent, Vikram. Very comprehensive talk, made very simple, difficult topic, like Khalid said. Certainly, I'm one of those. Very poor anatomy I have. So it was very enlightening, although I'm not sure. I think I'll restrict myself to the left lobe. But really, really excellent and interesting session. Thank you very much.
The basic dictum is all ultrasound is so enjoyable. It really doesn't matter which probe you have in hand. So
absolutely,
you just have to enjoy ultrasound.
Actually, it's not only ultrasound. Whatever you do, if you're not passionate and you don't enjoy it, then maybe it's time to leave it.
Yeah, that's right. I agree. But I think, Saad, the age group that you and I belong to, the new people, the younger people, Khalid and Vikram, they are much more tech savvy, and they're better able to understand the emerging technologies. So I agree that Vikram has pointed out very rightly that we have to have better modalities. We have to have more science put into the endoscopic ultrasound machine to evaluate the liver more thoroughly and more comprehensively. It's an upcoming field, interesting field. Lots of people are taking interest, and Vikram has been one of them who has published plenty of papers on this. And I see him on many platforms presenting his views on endoscopic ultrasound. I'm really thankful to you, Vikram, on behalf of Pakistan Gastroenterology, AEG, University of Health Sciences, Dow University of Health Sciences, CPSP. We are very thankful to you for illuminating us on a very important subject, a new subject, and at the same time, thankful to Wilson for providing us the platform. And I'm also thankful to the audience for sparing time. Khalid, I know it's very early on in your country. I'm really thankful to you. And
it's not early. It's at almost 10 a.m. So, but yeah, for me on weekend it's early. Thank you.
No, this is very very late for Khalid.
Yeah. At the same time, a happy upcoming Diwali to Vikram and rest of the people in India. With that,
yes, thank you.
Thank you all for sparing time. Take care and good night.
Thank you, Dr. Tyab. It was my pleasure. Dr. Khalid, say hello to Sham from me, and thanks to all. Thanks to all.
Thank you on behalf of Wilson Pharmaceutical, sir. Thank you so much, and we'll see you again.